Bueno, pues vamos a dar comienzo a la segunda sesión del Congreso. En esta segunda sesión vamos a adentrarnos en el campo, en las experiencias concretas que hemos recabado en telemedicina en las áreas, en países como Noruega, México, Chile, también en España, Dinamarca. Entonces, bueno, vamos a hacer una comparación de todas estas experiencias y vamos a tener la gran suerte de poder contactar en directo con compañeros que están muy lejos de nosotros. Entonces, bueno, yo creo que va a ser una experiencia también bastante interesante. Vamos a comenzar con el primer ponente, que se llama Dr. Knut Lappegård. Él es profesor de la Universidad de Tromsø, catedrático de medicina. También es médico internista y cirujano torácico del Hospital de Nordland. Para aquellos que no conozcáis el norte de Noruega, él vive en Bodø. Bodø es una ciudad, una de las más grandes que hay en el norte de Noruega, tendrá unos 50.000 habitantes, a pesar de ello es una de las más grandes. Y son zonas que se caracterizan fundamentalmente por las grandes distancias que hay entre las diversas poblaciones. Entonces, los aparatos, la telemedicina, la telesalud está muy desarrollada en estos núcleos urbanos y hemos colaborado ya con ellos en varios proyectos de investigación. Y bueno, en este momento Knut nos va a presentar su experiencia utilizando estos mecanismos para monitorizar pacientes en cardiología, en el caso concreto de marcapasos. Entonces, bueno, él va a presentar su ponencia en inglés durante unos 10 minutos aproximadamente y luego podremos preguntarle. Si alguien le quiere hacer alguna pregunta y la quiere realizar en español, se lo puedo traducir sin ningún problema. Así que bueno, vamos a darle ya paso a nuestro amigo Knut. Knut, you are welcome to start when you want.
Thank you, Daniel, for your introduction. And I apologize for my poor Spanish. I understood a couple of few words, but not so much. So this presentation will be in English, and I hope you will understand. And if you have any questions at the end and prefer to ask your questions in Spanish, I'm sure Daniel will be happy to translate. I'm going to introduce you to the field of remote monitoring of cardiac electronic devices and how we can use that to improve patient quality, reduce costs, and reduce travel expenses, especially exemplified in rural areas like here in northern Norway. As I understand, not all of you are very familiar with all the different aspects of the telehealth regarding different diagnoses and illnesses. So I'm going to tell you a little about what these cardiac electronic devices are and what they can be used for. We have pacemakers that we use for the treatment of slow heart rates. We have defibrillators, ICDs, that we use for the prevention of sudden cardiac death. We have devices to treat heart failure, and we have also implantable loop recorders that we call them that can monitor heart rhythm to see if disturbances in heart rhythm can account for symptoms of a specific patient. As you can see from the numbers, there are almost 1 million such devices implanted in Europe every year. So we have around 10 million patients in Europe that carry such an CIED, a cardiac implantable electronic device. So this is a huge challenge to the health system, both in terms of time consumption and also expenses due to, for instance, traveling. These are some of the indications that CIEDs are used for: bradycardia, slow heart rates, very fast heart rates, and also heart failure, as I mentioned. These patients who carry such a CIED, they need regular follow-up. They have to travel to the hospital. Some of them are old and need to have somebody to travel with them. This is time-consuming for several persons, There are travel expenses, and there's a number of highly skilled persons in the hospital that use a lot of time to control these CIEDs. So this is the cost aspect of it. Furthermore, follow-up is intermittent, for instance, once a year or once every 6 months. And problems related to the implant may arise between these visits. So if we could be able to monitor these devices remotely from the patient's home, we could maybe improve quality of follow-up. We could reduce inconvenience for the patient. We could save money for the hospital. We could reduce time used by the hospital staff and also by the patient himself and by the caregivers. We'll skip this picture and show you this, how this remote monitoring works. This is the chest of a patient that has a pacemaker implanted. Then this patient, either on his nightstand next to his bed or in his pocket, he can have a transmitter that receives information from the pacemaker, and then the transmitter can send this information wireless through the GSM system to a server. This server can be placed anywhere in the United States, in England, in Germany, whatever. And then the doctors in the hospital can access information from this transmission through the internet. The doctor will have access to his or her patients that are assigned to his clinic, to his hospital. Information from all the patients with this similar or the same brand of pacemakers will have their data transmitted to the same servers, but the doctor can only access his or her own patients. So such a transmission provides the physician with a lot of information. We get information regarding the battery status, of course, of the device. Is the battery being depleted? Do we have to replace it? We get information about the leads. Is there a break in the insulation? Are the leads functioning the way they should? And we get a lot of clinical information regarding the heart rate, whether the pacemaker has been used, whether the defibrillator has given shocks to the patients, and so forth. So there's a lot of information available when we access these files and the web page. So there are a number of potential benefits of this remote monitoring. It will probably increase the safety for the patient. The physician, he can receive a warning if, for instance, the battery status is low. The physician can choose to receive a phone call from the system, and a text message from the system, and email from the system. And one or more persons in the hospital can be warned. So we will receive a message, for instance, if the battery is being depleted, or if there is a lead fracture, or lead insulation defect, or anything else that compromises the function of the device. We also get information that will have impact on clinical decision making. We receive information or an alarm if the patient has certain arrhythmias. We can tailor the medical treatment to reduce the risk. We can receive information if the patient accumulates water, as in heart failure, and we can increase diuretic treatment, for instance, to avoid hospitalization of the patient. It's also cost saving for the hospitals. It's cost saving for the society and for patients and for the caregivers. The patient may not have to travel to the hospitals. The caregivers do not have to follow the patient. The staff at the hospital can check the web pages for a number of pacemaker patients instead of spending time in the outpatient clinic examining each and every patient. travel expenses, which is an issue in many parts of my country, will be reduced because the patient does not have to travel to the hospital. There have been a number of studies to look into this. The pacemaker manufacturer have made their home monitoring systems, but the documentation that these ideas about reducing cost, improving quality, and so forth, they have so far not been very well documented. There are a number of studies that show benefits of this remote monitoring, both in terms of clinical outcome and in terms of economy and patient satisfaction. Here are some examples, and Spanish researchers, including our chairman today, has been involved in several of these. And these studies have shown that you can reduce cost and improve quality of life for the patients. However, these studies are largely non-randomized. The patient selection is possibly, we don't know, it's possibly biased. And we really do not know which patient to use these systems for. Should it be for everybody, or should it just be for a selected group of patients? Will we achieve the economic benefit if we give this system to every patient, or do we need to select patients carefully in order to have the advantages? So most studies so far have been non-randomized or based on registries. And there have recently been published 2 randomized trials in high-ranked journals looking into atrial arrhythmias and heart failure hospitalization in remote follow-up. And these trials, they could not show any benefit of home monitoring. So it seems that the benefits achieved in non-randomized studies kind of are disseminated or disappear when the patients are randomized to either a home monitoring system or ordinary follow-up. So this paper in Europace could not show any benefit regarding fluid monitoring and heart failure hospitalization. And this, published in European Heart Journal last year, could not find any benefit regarding atrial arrhythmias and using home monitoring to guide anticoagulation. So, as I mentioned, we think that remote monitoring can be convenient for the patient. It can be cost-saving for the hospitals. It can aid clinical decision-making, and it can improve safety for the patient. But we do not know if this is for all patients or for a selected group. Regarding convenience and economy, I have to show you a picture of my country, Norway, way up in Northern Europe. And where I work here in Bodø, north of the Arctic Circle, here is my hospital in Bodø, in Nordland, in Nordland County in Bodø, and our pacemaker patients live within this circle. And that's more than 250 kilometers from the hospital to the limits of the hospital region. So 250 kilometers driving in a car or a taxi, followed by a caregiver. This is, of course, very expensive and time-consuming for a number of persons. So if we can improve that, it would be a great improvement. We sometimes have to have air transport from the islands outside the coast, and especially during the winter, we have very challenging weather conditions. So it would be a great advantage if we could show that for selected patients, remote monitoring will be an advantage. So together with Spanish researchers, our chair today, and Antonio Lopez Villegas, we have designed a controlled and randomized study trying to look into this. It's only one center. That's an advantage. We don't have the possibility of introducing bias by different hospitals doing things differently. We have one home monitoring system from the pacemaker manufacturer called Biotronic. We have included 50 patients, and they all accepted participation in the study before they were randomized. So they did not know if they would receive a home monitor or just the ordinary follow-up. They accepted participation in the study without this knowledge. So the patients were randomly assigned to either one of the two groups. We plan for a follow-up after 1 year, and the last patient was included in November last year. So the results from this trial will become available now in late 2016. There are a number of readouts in this trial. Of course, we look at patient satisfaction, quality of life, health questionnaire. We look at formal and informal costs, patients and caregivers. Do they have to use time to follow the patient to the hospital? Do they have to stay away from work and so forth? We look at hospital resources. How many visits do the patients have to the hospital? How many letters do we send them based on home monitoring? How many phone calls do we receive? And of course, are there any hospitalizations in either of the groups? Are the patients hospitalized due to heart failure or other problems? And can this be avoided by home monitoring? We look at travel expenses, and we look at impact on clinical decisions. For instance, anticoagulants in atrial arrhythmias. So there are a number of readouts that will be drawn from this trial. These are just the baseline characteristics of the patients. There is an equal number of men and women, 26 men and 24 women, and they were randomly assigned to either an active home monitoring group or a control group. And there are no differences between the groups regarding age and gender and so forth. But unfortunately, I do not have any results so far to show you. We'll have to come back to that next year. So to summarize, home monitoring of cardiac implantable electronic devices may be a way to reduce costs. It may increase patient satisfaction, and it may aid clinical decision-making in patients. Several unrandomized trials indicate a positive effect, but the randomized trials that have been performed so far have not been too convincing. So it may be that careful patient selection is necessary to achieve a positive effect. Maybe we should not give these home monitoring systems to all the patients, but to carefully selected patients that we believe or know that can benefit from such a system. And the results from our study will be analyzed now during the winter, and we hope to publish these results during in next year. And maybe I can come back and tell you about the results in a further conference sometime next year. Thank you.
Thank you very much, Dr. Knut Lappegård. We are pleased, and we can see very clear how important is the added value of all these home monitoring devices. Pero bueno, si alguien tiene alguna pregunta para el Dr. Lappegård, antes de que se marche, porque no se va a quedar hasta el final de la sesión, obvio, porque va a ser en castellano. Well, Knut, there is no more questions in the room, but I would like to have a question, because we have seen very clearly the added value of the home monitoring systems, and perhaps in 10 or 20 years, all patients go to the home monitoring system. That's my impression, but you are working in the field, and I would like to see your view on that. If all patients in the future will go to home monitoring or not. or you think that will never be possible?
Well, there is also a cost. We have to remember that with the home monitoring systems. The companies don't give us this for free. There are differences how this is charged. Some companies charge a one-time fee, and some companies charge kind of a subscription. So it's important to see if all patients will benefit from this. Another important question is that, as I showed you in one of the first slides, there is an enormous amount of information available through this system. And I think as doctors and as health care professionals, we have to be aware that there is a possibility to drown in this information. If we get this information on a daily or weekly basis from hundreds of patients, it will be very important that we have strict guidelines on what to look for, what to act on, and so forth. Because if we want to, we could, I'm sure, occupy dozens of nurses and doctors to sit and remotely follow up every pacemaker patient on a daily basis. And we don't want that. Then we don't use our resources in a better way. So we have to be very aware of how to use this system. How often should we access the system? How often should the system transmit information to the hospital? And there are also a number of legal aspects linked to this. If there is an email to the hospital from the system telling us about some kind of a problem, what are the legal aspects, who are responsible to follow up, and so forth. So even though this seems to be a very nice way to improve patient follow-up, there are a number of issues that are not resolved and have to be resolved if we are to give this to every patient.
Okay, Knut, thank you very much for your clear answer and also for sharing your experience, your great experience in a home monitoring system with all of us here today in Madrid. So, greetings from Madrid and see you soon.
Thank you. Greetings from Buda and hope to see you soon.
Bye bye. Hej då.
Bye bye.
Bueno, pues pasamos ya al castellano y disculpas también a las personas que no hayan podido seguir esta presentación en inglés, pero al querer tener esta proyección internacional en el Congreso, pues bueno, ha sido algo que queríamos también traer dentro de este evento, ¿no? Bueno,